None.
And the slides we tried to have
Yeah, be prepared to cry at least once a week.
and last week I'm 5.5 slides. I'm not. There you go. That's perfect.
I didn't think I had a life undergrad, and I was wrong. No, yeah, I thought I didn't have a life, but this is like more than extreme.
I'm gonna go grab it.
It's literally how.
Here's the thing.
Yeah, you have one up here. Where? I think there's just one. Sorry, I grabbed you one. It's okay.
I grew up next door. I went to Bethany Middle School.
I heard my name.
Tell someone.
The town.
I got it.
Who doesn't want to talk about it?
I did my fan. You know what I did?
I was thinking about pharmacology and objectives, and like all of her test questions come from here. So we don't have to memorize the full package. Like you look at the answers and you know that's what you need to study. Which is really nice in this Pharm. You kind of building all the
Is your boy coming here this weekend? Yes, actually. That cracked me up every weekend when he got good.
Honestly, you see it. We're also yeah, I was gonna say you're not like village without like driving. Like if I went to Nebraska, I'd see it. If village is outside, that'll be good. It's like an hour and a half away. Right. I dropped on like an hour before flight. Right.
kind of the filler.
All this stuff in a carry-on bag for a week. I guess he's a boy. Oh, my hand.
I never checked my bag.
Yeah.
It might be good for
That's why I can't get by.
my grandma's body is like taking that beach. Really fast paced. The fact that you've had 2 semesters would be so nice.
John Hart.
You have 24/7. So study in the evening or on the weekend, anything like that.
I love John Hart. I bought my ex toiletry bag
He's
for Christmas.
non-stop for like 4 weeks.
Shave K.
I'm like, yep, the very first 4 weeks of school was non-stop and that. So it gets you familiar with everything, and then our program is systems-based, which is right now. We just started cardiology recently. Before that, we did pulmonology.
Like during class, I feel behind you. I feel like I feel like it's getting behind you right now.
Have a good weekend? Yes. Louis. So Cardinals?
Yeah.
Yeah.
I'm from Missouri too, remember?
Oh, that's right. We talked about
Yeah.
that. Yes. Okay, so acute coronary syndromes. What'd you learn? Oh, sorry, we have a visitor. Have you been here all afternoon?
No.
Did you just come in?
Yes.
Okay, so Stacy, want to introduce?
This is Susanna. Is that how you say it? Okay.
Say it again?
Susanna.
Susanna?
And she is at SMU and she's graduating in 2 weeks and is interested in starting our program.
Great. What are you majoring in?
Biology.
Biology? Okay, very good. So, welcome. We're glad you're here.
Thank you.
Hope you enjoy it. So what'd you learn? Acute coronary syndrome. Troponin is what? Oh, wait a minute. A way to measure it? Okay, way to measure what? Injury. Okay, so it's what are troponins? What are they?
Cardiac biomarkers. Inside the cardiac song, they're released.
Okay, so like a lot of things, we talked about ALT and AST, the same thing, is that when hepatic cells are injured, they spill their guts, and we measure their guts in the blood. So troponins are similar. What else did you learn?
Do not use Mona.
Mona is
What is that?
Morphine, oxygen, nitrogen, aspirin.
Okay, well, and so why did he say that?
Morphine.
Morphine has a
Morphine's bad, okay.
30% increase in mortality rate.
One at a time.
Oxygen hasn't shown to be like beneficial in research, and in fact, if you over-oxygenate them, like you can have the free radicals and everything. So you should only oxygenate if they're hypoxic.
Okay, so do you give you some criteria?
Hypoxia. Just hypoxia.
Okay, and what else? Nitrates?
Morphine.
Don't use nitrates, really.
There's no evidence for it, but it's being used.
Pardon? Use with caution, okay.
The aspirin, of course.
And what about aspirin? Okay, so I'll give you some other data to go along with that. What else? So you'll find a lot when there are gray areas, when people differ, it's because it's what information they pay attention to, or which information they put more stock in, and experience. So it is very worthwhile to listen to people of different opinions, so you can start to figure out why. Because he is very experienced and has done this a lot, and so it is important to listen to his experience. And I'll give you some other data and some other information along that line as well. Anything else you learned? Yes?
I've always, is coronary artery disease the same as CAD, the same as ACS? That's all I've ever heard of that.
No,
No?
not the same.
Okay.
What's coronary artery disease?
Apparently I don't know.
Okay, well, what do the words mean? Coronary artery disease, what does it mean?
Coronary artery.
Okay, so a disease of the coronary artery. So what is that usually referring to? What's the disease? Atherosclerosis. Okay, so it's atherosclerosis in the coronary artery. Can you have atherosclerosis and not have acute coronary syndrome? Yes. Okay. So acute coronary syndrome, there are symptoms that relate to that. Symptoms, blood, laboratory EKG changes that define what an acute coronary syndrome is. So yes, you can have no disease, asymptomatic, you can have chronic, stable, which we'll talk about I think on Friday, and then you can have an acute time. So has Dr. McNeil talked about coronary artery disease?
We did atherosclerosis today, but.
You did atherosclerosis. Okay, so what'd you learn about atherosclerosis?
It's bad.
It's bad. It develops when?
Over time.
Over time, like when does it start?
Decades.
It starts when you're a kid. You've already got it. You do. So everybody to some extent has it. Will it play out in your lifetime? Maybe not. Maybe it will. Depends on your risk factors and what other things here. The morphology of your coronary arteries, your family history, what genetics, what do you do to yourself? Do you smoke? Are you a couch potato? What's your cholesterol? What's your blood pressure? So lots of things play into it, lots of things. That's why not everybody in the United States has heart disease, but everybody has some degree of atherosclerosis. So how does atherosclerosis happen? It's where the plaques break off. How's it start?
With LDL.
So the endothelium is involved. How do we get to it? What's the early? So fatty streaks, foam cells. What are foam cells? Macrophages that have ingested lipids. But where does all that take place? Okay, inside the artery. And where inside the artery? The intima. It invades, so cholesterol moves into a space where it should not be. And so the body doesn't tolerate that very well. When things get to where they should not be, the body usually has some kind of response. So it sends in the troops. It sends in macrophages. It sends in lots of cytokines are also play into that, collagen. And they try to contain those lipids. But what happens over time? Does it arrest? Does it just stop? No, it tends to grow over time. It's a very slow growth. Sometimes it disappears and will come back. So we start to appreciate that. And sometimes it really gets, why does it cause a problem? Why do we care one whit about it? Because it can grow so big that it can occlude. And did you talk about vulnerable plaques or, okay. So I'll get to that. We'll get to that in the talk. I put that in there. Okay. All right. So how do we get to atherosclerosis? You asked about atherosclerosis and coronary artery disease. So it's a continuum. So it's from foam cells, fatty streaks, to occlusive disease, to then occlusive disease that then becomes an acute event when plaques rupture. Okay. Then we get heart attacks. Then we get STEMIs and non-STEMIs, and now it has new words and NSTEs, acute coronary syndrome. Okay, so we're going to talk about the drugs that we use. So also let's look at this is kind of a flow to think about. So if you do not have coronary artery disease, we consider you a primary prevention person. So primary interventions or prevention means we are trying to prevent a disease from happening. Primary prevention can be promoting healthy lifestyle. We want you to eat a good diet that's low in saturated fats and high in other things. So you all looked at your diets, right? Okay. We talked about LDL and saturated fats and how that is a very good substrate for the liver to make all kinds of cholesterol. And so that's one of the reasons we looked at it. Primary prevention may also be that we're looking at your risk factors. So what are the cardiovascular risk factors? Okay, age. So cardiovascular disease tends to happen as people get older. So age. Family history. Family history is very strong. You have to pay attention to it. So when does it matter? So family history it has some definitions to it. Do you know those? Male, female, differ?
Male, females it's 55, males it's 40.
The risk goes up in males over the age of 45, women over 55, but when do we pay attention to your family, to your parents? Have you had those? You haven't covered cardiovascular risk factors? Okay. So if you have a brother or a father who died suddenly, has had a cabbage, bypass, angioplasty, some known heart disease, under the age of 55, you are considered at higher risk. Women's under 65. Okay. So women have about a 10-year buffer in there unless they have diabetes, and that wipes that buffer out. Okay, so we pay attention to family history. What else is in there?
Race.
Pardon?
Race.
Is race a risk factor? I don't know then the cardiovascular risk factors that is considered.
That was for treatment, but not that.
They may have higher, but it's not considered a risk factor. It's the factors that they have, it's the risk they have. Okay. Obesity is an indirect risk because it usually goes along with others. What are the big ones? Diabetes, smoking. Smoking is one of your highest. Hypertension. Sedentary is a kind of another secondary. Hyperlipidemia. And the lipoprotein is most associated with heart disease is what? LDL. It's almost directly proportional. The higher the LDL, the higher the risk for a coronary event. Okay. So primary prevention can take in a lot of things. It can be just simply lifestyle, exercise, eat right, maintain a good weight. Or it can be interventions. We can say your cholesterol is high and given your family history, then we're going to treat you with a statin. It can be treating hypertension, because that's a big one. That's a big risk factor for the development of ischemic heart disease is hypertension. So that could be an intervention. Can't do anything about your parents. Can't do anything about your age. So there are risk factors that are not modifiable and there are modifiable risk factors. So when you look at your patients, especially if you're in primary care, the one thing you want to be looking at is what are your modifiable risk factors and starting early and educating people. Okay. So once we get to ischemic heart disease, coronary artery disease, another term would be, is it chronic or is it acute? And in acute, we get down to, if they have an event, then we move into secondary prevention. Then we want to prevent them from having another event. So people who have had a heart attack, who've had angioplasty, CABG, those folks are secondary prevention. We want to keep them from having that occur again. And some of the drugs are going to have stronger indications for secondary versus primary. We don't treat everybody primary because everybody's risk is not the same. And in some people, it causes them more harm than it would do them good. Secondary prevention across the board, we're pretty much going to treat everybody the same because risk is very high that they will have another event. All right, so that kind of sets the stage there. Okay. All right. On the very first page, you'll see there is, I gave you a guideline source. The American College of Cardiology has on their website great education. They have all the guidelines for everything cardiology on them. I pulled 4 of them off and have posted them to D2L. So you have the most recent guidelines for non-stimming, stimming, the use of dual antiplatelets, and then the use of PPIs with antiplatelets. So those are posted. Okay. So according to those guidelines, patients, early therapy for people who come in with an acute coronary syndrome, the recommendations out of the guidelines is oxygen. And they use, their guidelines are an O2 sat of less than 90%. They state in there, though, if it is deemed that the person would benefit from it, even though they have a higher O2 sat, that it should be used. But in people who have normal oxygen saturation, they don't benefit. So there isn't really a reason to do that. Other things would be the use of sublingual nitroglycerine, aspirin, and or another antiplatelet, which we'll talk about in detail. The other things is that we're going to start some things right away. So if they're not on a beta blocker, we will do that, if a statin and an ACE inhibitor. Go down to the goals of therapy. So the goals of therapy, you should already have discussed, is one is we want to restore blood flow. We want to limit the ischemia. We want to reverse it if it's possible. If it's not, we want to keep it to the smallest area that we can. We want to make them more comfortable because they will be having lots of symptoms and pain. And we want to keep them from dying. So those are our big goals that are going to drive what we do. Time is of the essence. We'll talk about this when we get over to the STEMIs, is how fast you get all this started, the better the patient does. The long-term treatment goals is we want to keep it from happening again, secondary prevention. We don't want them to reinfarct because eventually they can develop heart failure from the loss of muscle, and then some cardiac death due to a malignant arrhythmia usually, or a plaque that ruptures. All right. If you look at the very last pages of your handout, your page numbers are really different. You've got 4 pages of charts. So this page is a comparison that I made, a table of the post-acute coronary syndrome drugs that should be started. You will come under a lot of scrutiny if you work in a hospital that these are done. Sometimes these just get forgotten in the emergency of everything that's done. And people exit the hospital faster than they used to. But these need to be started and the patient out on the, as they're, and taken as they go out the door. The next is you have a rapid overview. It says here's what should be done. The next is the management of acute unstable or non-STEMI, and then the last is acute management of STEMI. Now, like I usually tell you, I'm not going to go to these and say and test off of this, but I'm telling you, it even helps me. Often I will go back and I'll look and go, okay, now where in therapy is it? Because so many things are happening at the same time, and some things have to come before another. These are really good tables, and they're very pithy. They've got a lot of good information in them. So that's what's at the back of the handout. Okay, and I refer to them sometimes in the text. Okay. All right. So back to presentation under unstable angina, non-STEMIs. Those are really a continuum. An unstable angina is just an early, usually, form of that non-STEMI infarction. So it's really important to address and to treat people with unstable angina. So the 3 presentations are angina at rest. That's usually not good. Angina that occurs when you're doing something it's not normal, but it's better because if it goes away with rest, that's a lesser concern. New onset angina or increasing angina. It's becoming longer. It happens more frequently. It lasts for longer. Maybe it doesn't respond to their nitroglycerine or their other medical management. Unstable is considered to be present, and there underneath, under that bullet, there are 3 things to think about. Ischemic symptoms are suggestive of acute coronary syndrome. There's no elevation in troponin. And there's a presence or absence of EKG changes indicative of ischemia. Non-STEMI is when troponin levels start going up. What's the caveat with looking at troponin? When are you going to draw them? There's a window. Pardon?
Peaks at 12 hours.
Peaks at 12. How soon can you see them?
3.
3 to 4. Right. So if you're too early, it may look like they may be normal. So initial management for unstable angina and a non-STEMI infarction are the same. Because sometimes you can't tell, especially if the person comes in early. Our goals are we want to prevent them from moving on to a STEMI or to die. We want to prevent the ischemia. Ischemic tissues are highly unpredictable and can give rise to malignant arrhythmias, which can then kill the person, like VFib. Relief of their pain, and then we want to keep them from further thrombosing or having an embolus off of their plaque. Okay, so medical management, page 5. So we talked about oxygen. Aspirin. So aspirin needs to be given right away. It's a very good antiplatelet. We want them to chew it up. So some things to remember is that aspirin often will come as an enteric form. Enteric coated means it's designed, it's been formulated to dissolve in the intestines. Okay, so we don't want to chew it up either. One, it's harder. So you could use a 325 aspirin, or you could give them, let's see, I guess you could give them 4 of the baby aspirin, or the children's aspirin, the chewables. The only thing with regular aspirin is that it's very caustic. So if they chew up a regular aspirin, make sure they wash it down. I've never seen that in the guidelines, but if aspirin sits in your mouth, it will burn your mouth. It will cause a burn in the mouth. So having them chew it up and swallow. So the recommendations are for 325. 325 milligrams, but you will see anyway from 162 to 325. You'll have a question, Kendall?
Oh, yeah, I was asking her if she heard about the chewing, because I messed it up. So it helps with GI symptoms, is that what you said? That's why you want to do a chewable?
No, you want fast.
You want fast?
You want its onset.
Sorry, I just missed it.
Right, so the problem is that those enteric coated are designed to not dissolve until they get to the intestines. You don't want to do that. You want it right away, so as quickly as possible.
Would the enteric ones just be the ones that they take like a daily basis?
They may or may not be on enteric coated. You're going to give them, now if they're at home and they did it, you don't have any control over it. But, and I would assume, anybody EMS? Not this class. I'm assuming they carry it that they carry the chewable.
Dr. Letassy, I'm certified, but I never practiced in Virginia and Rhode Island, and we were not allowed to give aspirin.
Really? So people could take it at home, but you all were allowed to.
There were only 4 things we were allowed to give.
And I'm certified too, and we were allowed to help them with their own.
Okay.
In Missouri, it had to be their aspirin, but we couldn't give it to them. But that was EMT, medics could give it.
Okay. Okay, let's go over how aspirin works. I think we've done this before, but let's go through it again. So aspirin in platelets, because our action with the aspirin is against the platelets. And platelets only express COX-1. Okay. So arachidonic acid is present in the bilayer, the lipid bilayer that is part of every cell membrane. It's attached to the phospholipids. There is an enzyme, that PLA2, that liberates arachidonic acid from the cell membrane, and then it enters the cytosol, and then there's lots of different things the cell can do with that arachidonic acid. It will be converted by COX-1 to intermediates, prostaglandin intermediates. We're not so much concerned about those. What we're after is that thromboxane. So thromboxane is a end product of the conversion of arachidonic acid to a prostaglandin to thromboxane. Okay. So thromboxane is important to us because it's a vasoconstrictor and it is a platelet aggregator. So when it's released, it will cause the platelets to be activated, and then they can become sticky, adhesive, and aggregate. So our goal in giving the aspirin quickly is that we can stop that thromboxane from being produced. And we can do it pretty quickly. Aspirin, and the reason we use the aspirin is because it's acetylated. It's an acetylated salicylic acid. That acetyl group attaches to the platelet COX-1, and it renders it ineffective. So aspirin can knock out 90%, I put it in your handout, of the COX-1. So it's very effective. And it will stay that way, and it's irreversible. So once you acetylate it, the platelet's done for, or that enzyme is done until you can generate more. Usually that means for the lifetime of the platelets. So the half-life of platelets is about 7 days. Takes you 7 days to turn your platelet numbers over. That's why when, as you go along further, when you're going to have a procedure done, and we don't want you to bleed, usually they'll stop your aspirin about 5 to 7 days before. That allows it to restore platelets there, or then functional. So kind of going down through that. So thromboxane, platelet aggregation, vasoconstriction, aspirin will block that. But it doesn't block. The good thing about aspirin is that there are a lot of prostaglandins that are very helpful, and it doesn't knock those out. So at very low doses, it's specific for that thromboxane inhibition. There's another prostaglandin called PGI2 that is also helpful. It's a vasodilator. It also is a platelet inhibitor of platelet aggregation. Aspirin doesn't affect that, so that stays intact. Okay? So that's why aspirin is our first drug, or one of our first drugs. Let's see. Look at all those. Okay, let's go over to nitroglycerin. All right. Recommendations by the guidelines are to give 3 sublingual nitroglycerins. What do you remember about sublingual route?
It's fast.
Okay, it gets past what?
The liver.
Liver. It goes directly into the bloodstream, so we don't ever worry about first pass when we give things sublingual. So it's very quick. The standard dose is 0.4 milligrams. You should know that because it's just, that's it. There's other doses, and I'm talking about how to use that. You can use an aerosol. If you look on probably your next page, you can use an aerosol as well, a mist. Some people prefer that. We usually space out nitroglycerin every 5 minutes. Most of the time, most people will respond within 2 to 3 minutes. It's very fast. If they don't get complete relief, you can give another one in 5 minutes. If they don't respond to that fully, you can give a third one. When you teach people about nitroglycerin, this is the way we teach them. Place one under your tongue, let it dissolve. If it doesn't give you full relief in 5 minutes, take another. And at the same time, be calling 911. Okay, so it's going to take them, 10 minutes to get those 3 in, if they even take all 3. This is for patients who have persistent chest discomfort, high blood pressure, or signs of heart failure. If they have hemodynamic compromise, the biggest thing would be is if they're hypotensive, because the nitrates will make it worse. Or they've used a phosphodiesterase inhibitor, so something like Viagra. Okay? If they've used one in the last 24 to 48 hours, you will cause a hypotensive crisis, so you won't want to get a nitrate in that instant. If the person is hypotensive and you need the nitroglycerin, you can use a lower dose. It comes as a 0.15, and it comes as high as a 0.6, which you could give if they're not responding to the 0.4. So it's kind of the range. So let's talk about nitrate's mechanism of action. So So nitrates come in, does the pointer work? Does this work, mouse?
Yes.
Okay, so the nitrates enter into the blood vessels, and they are converted by this mitochondrial enzyme into nitric oxide. That's the key. Nitroprostoxide, another very powerful drug that we use to lower blood pressure, is a direct nitric oxide provider. So this nitric oxide binds to this guanylyl cyclase, an enzyme, and it helps to convert GTP to cyclic GMP. Okay. Follow down through there. Cyclic GMP has two actions. One is that it lowers the intracellular calcium concentration. So contractions go down. So there's not as much calcium available for there to be a muscle contraction. The other thing it does is it works with this enzyme called myosin LC phosphatase. If you look on this side, that myosin LC phosphate is the form of myosin that can interact with actin. So when you have actin and myosin interact, you get a contraction, right? What this enzyme does is it dephosphorylates. So it takes that phosphate group off, and it can no longer interact with actin. Is that not cool? Cool. So you get muscle relaxation. So calcium goes down, intracellular calcium, and the myosin cannot interact with the actin. That's why you get vasodilation. Questions about nitrates? Okay, so where do nitrates work? They're very effective vasodilators, but their main action is on the veins. They do have some arterial effect, but it's predominantly vein. And where they work is on that, in that smooth muscle layer. So let's look on the next page where it says multiple mechanisms to cause relief of angina. You have vascular effects, you have cardiac effects, and you have coronary effects. Venous is greater than arterial, the effect. Veins are capacitance vessels. Okay? They can hold a lot of fluid. So when you are standing or where you're in position where you're pooling, or if you get edema, it's usually on that, you get it, that venous side can hold a lot of volume. The arterial side cannot. So if you can relax a vein and you increase its capacitance, what happens to how much blood you can get back to the heart? It goes down. So what do we call that? A reduction in the amount of blood that is returned to the heart is what? Preload. You heard that term? Yeah. Preload. So nitrates are very good at reducing preload. So how does that help us? It decreases stroke volume. Let's see if I've got it. Decreases stroke volume. What else does it? What else would preload help? If I'm not putting as much volume in the ventricle, how does that help me? Oxygen demand is less. Right. It also may decrease the pressure in the pulmonary system. So particularly for people who've got pulmonary congestion, which will happen if the heart can't pump right, then that goes down. Okay. So you get a decrease in preload, which decreases that pulmonary capillary wedge pressure. That's what's helping with the pulmonary congestion. To a lesser degree, it will reduce afterload. So what's afterload? It's the resistance the heart has to overcome in order to eject blood from the ventricles. Okay. So how does that help us? Decreases the work of the heart, decreases myocardial oxygen consumption. Okay. The other thing it does is it helps with the coronary arteries. So those coronary arteries will vasodilate, so it may help in areas where there's ischemia. It will help get more blood to collaterals. What are collateral vessels? Alternative route. So if a process to occlude a vessel is slow, the body will start forming other vessels around that. So that's good. If you got good collaterals, then you probably can tolerate a lot more problems in that artery, more occlusion, because you've got blood flow that will go around it. So the nitrates will help also with those. It'll vasodilate. So it helps in limiting ischemia. So lots of good things with nitrates. The problem, and they're very quick. So adverse effects are sometimes what limit us. That vasodilation can cause headaches, and they are intense. Patients usually have described it to me as that I feel like the top of my head is going to blow off. That's what they usually tell you. It's real, and sometimes patients can't tolerate. The headache is very intense. So that's one. The other is hypotension. So you can look here and see your determinants of blood pressure is what?
Cardiac output.
Cardiac output times what? Total peripheral resistance. What are your determinants of cardiac output?
Heart rate.
Okay. So we get some decrease in this. We get a lot of decrease in this. So what that helps us with blood pressure, but what's the reflex response of the heart to keep up blood pressure? It increases heart rate. So if nitrates are used unopposed without a beta blocker, then you can get tachycardia. So that can make things worse. So that becomes the problem in using nitrates. So you have to you've got to use them with a beta blocker. Okay. So, doesn't it all make sense? Yeah, you're going. Okay. So if you can't use sublingual, you can use IV nitroglycerin. Same kind of problems here. They're very same thing, but you can put it directly in. You can titrate it to effect. Usual dose listed there is 40 micrograms a minute. You can start as low as 5 and titrate up. I think the top is like 400. So it has a wide range, dosing range, which makes it much easier to be more specific. So now tell me why he told you not to use nitrates.
He just said that there wasn't a specific study or study done that said this is how it works and it is beneficial. Or that it
reduces symptoms.
Yeah, he said he uses it for pain control, but he still uses it all the time.
Now that is a good point, because if you're going to avoid morphine or opioids, then you have to have an alternative. So a lot of pain control now, instead of using morphine, it's directed at using nitroglycerin, oxygen, and beta blockers.
He uses fentanyl.
We'll talk about that.
He said that also if you have an inferior MI, if you give them nitroglycerin, it'll increase hypotension.
Yeah, it will. It will. You have to look at the patient. So if they are hemodynamically unstable, you would probably not use this, or the dose is going to be pretty low. But it's part of your armamentarium, so you have to appreciate where it is and what it does. These are drugs that have been around forever. So the studies is anybody going to do a study? Probably not. They might use it as a part of another study, but probably are not going to get those big groups that are going to look at this. I just don't know if that data will come out. Okay, I put the morphine stuff in here because I know what he says, because I follow him every year. So let me give you some other information. Morphine has been used for probably 100 years for chest pain. So lots of experience, a lot of people are going to go to it because of just tradition, history. So the reason why is that, so we talked about the Crusade study. Okay, did you talk about study design? Look at the study design. It's non-randomized, so what does that mean? Anybody went in, it was a registry, okay? So they had a registry of 60,000 people. Now that's impressive. They had a lot of people. It's retrospective, which means you're looking backwards. And it was, there's two things, there's another thing. Observational. Okay, that is just like the death knell of how much stock you put in the outcomes. But it's usually the first place things start, where people start to notice, hey, we're seeing a lot of this happen, and then people then take another step and organize or execute studies that are more well designed. So this is observation. This is just people seeing what they see and writing about it. The one thing that caught people's attention is that the odds ratio for people who got morphine and had a poor outcome compared to those who didn't get morphine and had a better outcome is an odds ratio of 1.48. So what's an odds ratio? What does that tell you?
Odds of it happening?
So it's the odds of it happening. So it's the odds of something happening if a factor is present compared to the odds of something happening if the factor is not present. Okay. So an odds ratio of 1.48 is significant. So it's something to pay attention to. But I'll tell you, these kinds of studies tell you and point to there's maybe a problem, but it never shows or demonstrates cause and effect. So if he wants to get after the nitrates, I'm looking at the Crusade study and going, all it tells you is that this may be the problem. It does not tell you cause and effect. Okay. Doesn't mean there isn't something there. So people started looking at that. And so what they've decided is that what happens is that opioids, like morphine, slow down the gut. And so what is probably happening is that they are slowing down the absorption of antiplatelets, especially those P2Y12s. That is what is thought to be the cause. So those drugs are not that old. So years ago, we didn't even have them around to interfere. But people have looked at time to platelet, how fast platelets aggregate. And they found that if you give morphine, it slows it down. So it's probably the absorption. So if you can get around that, then it's not a problem. There is an IV form of one of the P2Y12s does come as an IV. So you could do that if it's important. So people have thought, well, does it occur with others? There isn't a lot of data. And I know he likes to go to fentanyl, but fentanyl has also been shown to, all the opioids slow down the gut, all of them. I couldn't find anything on Dilaudid, but fentanyl already has a level C, so it already has, you better monitor. So probably all the opioids do this to an extent. Okay. The drugs like clopidogrel and brassogrel are going to have more of a problem because they have to get absorbed, move through the gut, the liver to be activated. Questions?
What if you have someone who's like an opiate addict and they're addicted to it or trying to, or just got back from rehab and they're like, no, I don't want anything like that to help me, but they're in a lot of pain. Like,
okay, well that's why now the recommendations are to optimize oxygen, nitroglycerin, and beta blockers. All your other stuff optimized to try to get pain relief that way. If not, then there is, it depends on where you are in the process of getting drugs in the person as well. So that's kind of my balance to his, to the information he gave me. I'm not saying he's wrong. There definitely is something there. And the options to get around it are not, there's not a lot of them. So beta blockers, let's talk about them. So beta blockers, unless there's a contraindication, should be started within 24 hours. Lots of good things with beta blockers as well. So beta blockers are going to work, primarily we're looking for those that will affect the beta-1 receptor. Okay? So it'll slow down heart rate. So that helps with myocardial oxygen demand. The beta blockers decrease contractility. That also decreases demand. They slow down heart rate through the AV node. They're dromotropic effect. They relax. They are good at cardiac relaxation. So that helps with oxygen demand as well. So they are preventing the circulating catecholamines, so you got norepinephrine and epinephrine circulating. Patients under stress, so those are probably elevated, so they're going to help also with those to prevent the effects of those circulating neurotransmitters. And they're going to help with blood pressure as well. On the let's see what page. Under cardioselective beta blockers, this is important. So we want to do cardioselective. So what does that mean? If we say cardioselective beta blockers, what are we talking about? We want beta 1. So some of the I don't know, it's page 11 on mine, but not on yours. 10, page 10. Cardioselective beta blockers. This is important. So at low doses, these beta blockers tend to be cardioselective for beta 1. If you raise the dose, usually at the higher ends, they lose that selectivity and they'll affect beta 2s as well. So the ones that are listed there are metoprolol, tartrate, and atenolol. Those are your best cardioselective. Here, salt matters. So metoprolol tartrate is the immediate release form. That's low pressure. The metoprolol succinate is the extended release, or the salt form used in extended release. So in this case, we would use the tartrate. We tend to use the extended release when we're getting into heart failure. When would we not use those? Well, we would not use them if you've got someone who is in heart failure or at high risk for heart failure. Bradycardic already. So a bradycardia would be what, a heart rate under 60. Or they've got severe reactive airway disease. Those are listed at the top. The other is we would start a statin. Regardless of what their LDL is, we would start a statin. LDLs are not predictable, are not reliable when somebody is in acute coronary syndrome. So even if you took them, they would not represent what they would be like if they were fine, in good health. So here, and look, we're going to do lipids in a week or two. We would use a high-intensity statin. So atorvastatin or rosuvastatin would fall into that. Strong relationship between LDL, and I couldn't find an LDL slide, but this shows you total cholesterol. So this is the Framingham data. You've got on the x-axis, you have total cholesterol, and on the y-axis, you have cardiovascular risk per 1,000 people over an 8-year period. So you see it's pretty much a direct proportion. In fact, it's I think every 2% lowering, or it's every 2% lowering of LDL gives you a 1% lowering in cardiovascular risk. I may have those backed up. But it tells you small changes in cholesterol have big changes in reducing your cardiovascular risk. Statins are one of the most potent drugs we have in terms of the lowering LDLs, and that's why they're preferred. So you would start them, and then you would recheck their lipids in about 6 to 8 weeks. Let me finish up this too, and then we'll take a break. So, going back to what we were talking about, atherosclerosis. So you've got here, this slide shows your progression from minimal disease up to a plaque rupture. So in that intima, you all talked about the movement of cholesterol into that layer of the blood vessel. That's usually LDL. HDL, what's the function of HDL? Why do we care about it? It picks up LDL in the periphery and takes it back to the liver. So the liver puts out LDL, it goes out, does its work. HDL is sent after it to pick it up, bring it back to the liver. The liver will take it up and will reprocess it and make other lipoproteins out of it or put out LDL again. So having high HDL helps to protect against that deposition of LDL in the intima. As you see in this, and this shows you just in a cartoon fashion how the impact on the lumen size is. Here you've got an intimal xanthoma. What is a xanthoma? What's xan? What's that? Yellow tumor. It's due to what? Fat. So you get intimal thickening over the years, and at the top you have that fibrous cap. That cap is really important. The thicker it is, the more stable that atheroma stays. Okay? The thinner it gets, then it becomes what we call a vulnerable plaque. And those vulnerable plaques are the ones that are most risk for rupture. So over time, they necrose. And this is a very thin, this is a vulnerable or thin cap atheroma. If it breaks or ruptures, then all those contents are exposed to the blood, and the blood will treat it as a thrombogenic event. And so it will attract the platelets, and that's what happens here is you've got a rupture, and then you've got this big thrombus. So that's what we're trying to do with those antiplatelets. Here is a vessel, I guess, of someone who died. Here is the plaque. So you can see how invasive it is. And it really didn't take up that much. This person may have been asymptomatic. And this shows you the cellular structure. So there's the necrotic center. Here's the thrombus. And this is a close-up and shows you where it thinned and eventually ruptured in those two areas. Okay. So that becomes then a thrombogenic event because tissue factor gets released, and that starts the whole coagulation cascade, tracks the platelets in, they form a plug. To me, these are just like a pumpkin pie. Now, I'm a terrible baker, but to me, a stable plaque is like a great pumpkin pie. You take it out of the oven, and it's perfect. I never can get them like that. As long as it stays like that, doesn't crack, you got a great pie. But if it collapses down and splits, and I don't know why sometimes the pumpkin pie comes out split, maybe you do if you're a good baker, but sometimes you get those cracks. So to me, this is what an atheroma is like, a good or bad pumpkin pie.
Letassy, to fix it, all you have to do is just smother it with Cool Whip.
Yes, that's true. Cover it up. And so that's what the body does. It smothers it with Cool Whip. Okay, let's take a break and we'll pick it back up with platelets on the next page. Let's start back at 2.